Hi there, and welcome to another episode of Contact Lens Spectrum Live, a live stream series presented by the publishers of Contact Lens Spectrum. My name is Lyndon Jones, and it's great to be here chatting to some of my friends and colleagues from around the world on the future of contact lenses. In each of these series of 3 programs, I'm going to be discussing the challenges and opportunities for industry, researchers, and clinicians to optimize the performance of lenses that we have both today and also what the future holds for contact lenses. Today, I'm very grateful to welcome 2 colleagues from opposite sides of the Atlantic. Dr. Loretta Schottker-Flynn is a professor in the Case Western Reserve University, Departments of Ophthalmology and Vision Sciences. She received her OD and MSc from the Ohio State University and a PhD in epidemiology from Case Western Reserve University in 2009. She's a fellow of the American Academy of Optometry and a diplomate in the Academy section on cornea contact lenses and refractive technologies, where she's actually the past chair of the section. Now, her major research interests include contact lens-associated corneal inflammation and infection, keratoconus, corneal transplantation, and contact lens-related biofilms. Exactly the things that we're going to be covering in this session today. Our second guest is Dr. Deborun Dutta. Deborun is a tenured lecturer at the School of Optometry at Aston University, Birmingham in the UK. Following his optometry degree, Dr. Dutta completed a PhD at the Brian Holden Vision Institute and the School of Optometry and Vision Science at UNSW in Sydney, Australia. Dr. Dutta is also a fellow of the American Academy of Optometry and a council member and fellow of the BCLA. His primary research interests, again, are directly related to what we're talking about today, being related to contact lens-related adverse events, antimicrobial strategies, which is what we're going to focus on, tear film, ocular surface, and dry eye disease. Thanks both. Thanks both of you for being here today to continue this series about the future of contact lenses. So as I've already alluded to, in this episode, we're actually going to be discussing the extremely important issue for both clinicians and wearers alike of how we optimize infection and inflammation in contact lenses. So let's begin with Loretta. Loretta, thanks very much for joining us today.
Thanks, Lyndon.
You're welcome. Let's discuss whether we've actually made any impact, you think, on reducing inflammation or infection with soft lenses over the last few years, and what your thoughts are on that.
Yeah, that's a great question. I think many of us think about this in what we can do with today's contact lenses, not in the future, but what can we do today to decrease infection and inflammation? So to cut to the punchline, daily disposables. I mean, that's been the biggest enhancement, I think, in our armamentarium of contact lens products in the past few years. And we have very good data to show that they definitely reduce inflammation. So something like 12 times over reusable lenses. Robin Chalmers gave us that statistic several years ago now, that the use of a daily disposable reduces, the impact of the non-infectious inflammatory complications, or the CIEs. Sometimes we call them CIEs. As far as infection goes, we unfortunately have not reduced the rate of infection. So microbial keratitis, ulcerative keratitis, so true bacterial usually, but it could be protozoan, it could be fungal, but true infection in the cornea, unfortunately, has not been reduced just yet. So study after study is still continuing to show that with daily disposables, we are still getting about the same rates of microbial keratitis. And these are in compliant wearers and in studies where we're handing them lenses and where there's no reason not to be compliant, we're still seeing it. So maybe we've just hit the bottom barrel of what it's going to be. Maybe we can't avoid it, but we'll talk about that a little bit more in a minute. However, we are seeing the severity of microbial keratitis reduced with daily disposable lenses. So we do have some very good evidence of that, and I can go over to some specifics if you want.
So in terms of severity of disease, we're seeing severity reduced, but no impact in terms of amount. Is that correct? But isn't that an amazing statistic? More than 10 times reduced CIEs with daily disposable. That's a great number for clinicians to have in mind, I think.
Yeah, absolutely. I mean, if you have patients coming in with red eyes, or, whether it's solution-induced sensitivity or kind of a hypersensitivity to staph bacteria, those blepharitis type patients, Number one thing, put them in a daily disposable. It doesn't matter material. It could be a silicone hydrogel. It could be a non-silicone hydrogel. They're all going to reduce the rate, presumably because they're reducing the bacterial bioburden in a storage case. They're reducing interactions with preserved solutions or with endotoxins that, are just, from the killed bacteria. So just by getting a fresh lens on the eye every day, you're going to reduce inflammation for sure.
That's a great lesson to think about. So a couple of questions as a follow-up to that, Loretta. Why is it that we think that daily disposables don't reduce MK in daily disposable? Do we think that maybe non-compliance plays a role? And then the second question on that topic would be, we've now got a lot of SiHy daily disposables. Have we seen any change in either inflammation or MK rates with SiHy daily disposables?
Yeah, and those are two great questions. Definitely non-compliance is an issue. So, we have to realize that our daily disposable wearers are not all wearing them for daily disposability. Yeah. And there's been several studies now that have shown that something like a third of daily disposable users report some sort of non-compliance. Either they're sleeping in them or they're reusing them. So they're using solutions in a storage case or they're sleeping in them. So we all know that extended wear is definitely a huge risk factor for microbial keratitis, even if you're using a daily disposable. So that for sure needs to be controlled in the studies that we're looking at. But even, just the reuse, putting it back in the storage case or using a preserved solution or whatever, again, is kind of taking away the beauty of the daily disposability. But we do know that there are high rates of non-compliance. But what we don't know is if we truly control for that, can we, improve, reduce the rate of microbial keratitis further? And I've tried to do that recently in a study I recently completed, and we presented this at ARVO, a case control study of about 150 patients that got microbial keratitis and 150 patients that did not. And looking at the data, a whole bunch of different ways, controlling for non-compliance. And I know Fiona Stapleton tried to do this as well in some of her previous studies. We cannot still find a protective effect of the daily disposables. So even the compliant daily disposable patients are still getting microbial keratitis. So we need to just keep an eye out on that, and hopefully Deborah can tell us maybe some other strategies that we can reduce it. But with today's current modalities, we cannot seem to get rid of this low level of microbial keratitis.
And that's the same with SiHy daily disposables as well?
So that's a good question. SiHy daily disposables are maybe we haven't hit market penetrance yet. So like all of our studies are still maybe several years old. Some of the epidemiological studies. The study I recently completed had a pretty good rate of silicone hydrogel daily disposable patients. But yeah, I was not able to tease apart an effect or a protective effect of the silicone hydrogel dailies. So we're not really being able to disentangle that, but we're not seeing an additional protective effect. Sometimes the silicone hydrogel materials take us the other way. We know in inflammation, the CIEs, there's a slightly higher rate in the silicone hydrogels. We don't know, we don't have enough controlled studies looking at the combo effect of SiHys and dailies, but we're not seeing a signal that they're going to reduce.
I think that's with reusable SiHys though, isn't it?
That's it, absolutely. Reusable SiHys have that signal, not with daily disposable SiHys. But yeah, we're not able to disentangle the effect, but we're not seeing a protective signal yet either.
Cool, interesting. Okay, so kind of take-home message from that, I think, is that as ECPs, even if we've got patients in daily disposables, we do still need to question our patients about, are you throwing these lenses away every day? I think that's something worth taking away from that. Another question here for me, Loretta, is do you think there's any inherent patient factors? Do you think that some patients are more likely to get infection and inflammation than others? Do you know anything about that yet?
Oh, absolutely. So the genetics of microbial keratitis is really a hot topic, and credit to the Australian groups who first postulated this. Nicole Carnt and her teams have postulated and found a few hits on some candidate genes. We've taken that one step further. We had an NIH grant actually to look at the genetics of microbial keratitis. And the reason why I became interested in this, and I'm sure most eye care practitioners can resonate with this, is how many non-compliant patients do you have that their corneas look beautiful?
Yeah.
They've never had a scar. There's no contact lens peripheral ulcer scar. There's no sign of redness. There's no GPC. And they abuse their lenses. We tell them not to sleep in them. We tell them to throw them away every so often, and they don't. But yet they're survivors. Yeah. There's something about these patients that is making them, have these high risk behaviors, but they continue to get away without infection or inflammation. So those particular patients interested me greatly. And I wanted to learn about them because they must be somehow genetically protected. And then we have these patients, like I said earlier, that sleep in their lens once, a daily disposable, and they wake up the next day with an ulcer. And so why is that? So yeah, definitely we think that there is genetic predisposition. And because we're not seeing these rates come down much further, even with our newest lens modalities, there is probably just this inherent risky patient profile that is genetically ingrained in them that is likely causing this predisposition. So we published our findings at the ARBO meeting back here in 2023. And our genome-wide association study, which kind of had a hypothesis-free question. We didn't go in there specifically looking for gene A or gene B. We didn't know what we would find. And we found 3 pretty strong genetic hits that we're currently still exploring. So these kind of genetic studies take years and years and thousands of patients to determine what the true genetic hits are and can they be replicated in different patient populations. But we do at least have some evidence that there is a form of genetic predisposition, and that could be why all of these newest, greatest modalities we're still seeing risk. Yeah,
that kind of makes sense, doesn't it? Fantastic, awesome stuff, Loretta. I'm now going to switch over to Deborah. Thanks, Deborah, for joining us on this, and we're going to turn to some of the things that you've been involved in, I know, in your career, and certainly some things that you're interested in for the future. And that is, give us a kind of look into the future. And what sort of future directions do you envisage that will help us as clinicians reduce contact lens related infection and inflammation?
Thanks, Lyndon, for having me here. Yes. So in the first ones, I would say more of a biocompatible materials at the moment we have in the market than we used to have a couple of decades back. And they're more inert in terms of how they react to the ocular surface. The events like mechanical events or non-sterile infiltrative events has reduced because of many of the materials are much less reactive or not like poking as much as used to be, I guess. Also, the future directions, if you look at, there are a few candidates on the pipeline which are being investigated and also are running clinical studies. So there are a few different approaches that we can actually try to make contact lens and lens cases sterile. And the antimicrobial strategies, the first approach could be something we incorporate or make a coating on the contact lenses itself. So it is kind of deterring pathogens to stick on surface of it. We can incorporate something in the blister pack solution, which is more of a daily disposable lens wearers, so that the tip of the finger contamination doesn't really pass on to the lens and that apply in the eye. And the last approach is something from outside, something we can do extra to the lenses and lens cases. So I'll go by one. The first approach is to incorporate and coat or put inside the matrix of the lens. We have investigated and many across the world are metals and metal oxides like silver, which kind of kills everything. Its structure is really good at killing it, and they're very good and good potential candidate. Zinc oxide is other one which actually does work well and has been investigated with contact lenses. The other, including this, is going to absorb and adsorbing substances like non-steroidal anti-inflammatory drugs, they are very good at inhibiting biofilm formations or amoebal trough attachments. So we've seen in some of the this kind of studies which they've been worked on. Selenium is another non-metal antimicrobial, which also has been investigated with a human study, which looked quite promising. But by far, if any of the materials and substances have been investigated in this kind of approach, is antimicrobial peptides. And the group in Australia, and I was lucky to be part of it, was the melamine and its subsidiary, the Melfor, etc. A series of studies which looked at safety, efficacy, and a large clinical studies too, which showed the reduction of infiltrative events by 50%. And its further research is on peptides, which it's kind of clever small molecules. I think they're trying to attach on contact lenses. And the good thing is they don't get digested with pepsin or other enzymes we have in our eyes, which is a good approach, I thought. The second approach I told you is more of incorporation of blister packs. These are large polypeptides, antimicrobials, not necessarily always kill bacteria. They can be bacteriostatic, which means they do not allow bacteria to grow, which kind of work in both ways to reduce this. The other approach are external interventions. Some of the research involved are UVC lights, which are, we know that we have been using it for water treatments, etc. They are broad spectrum antimicrobial. They kill everything. They kill bacteria, fungus, or acanthamoeba, etc. And having this on the contact lenses or lens cases, they're pretty good. And there's been publications and reports on that. In fact, they're one step ahead. Contact lens or infection inflammations, the suggestion is they can also be used for just infections in the eye, and bypassing the whole drug resistance problem at the moment. So they're quite interesting and novel approaches around, and many of them are fairly successful in clinical studies.
That's awesome. So that kind of covers the material side of things, but of course that's really going to be great for daily disposables as well as reusables. But we know that about probably 50% of patients are still using reusable lenses, which brings in that case aspect. And we know that case is nightmare in terms of producing infection. So what do you think is going to happen to reduce the contamination of lens cases that can help us with this issue?
Yeah, I mean, the guidelines sometimes say to discard lenses after a month, or sometime after 3 months, sometime after the contact lens solution is over, so that patients using lenses for 6 months, they still don't change the lens cases. That's a good point, Lyndon. So there are different approaches here, I guess. And we had silver impregnated contact lenses, and we know the series of tests in laboratory and both in clinic, they do reduce contamination and reduce the biofilm formations in the lenses. That also, it's been looked that if that reflect in reduction in contaminations. So if you can reduce the contamination in lens cases, does it really reduce inflammation when the patient's wearing lenses? So they have been successfully tested on that. So this is quite so to reflect further. Furthermore, some of the clever and innovative materials were used, and they are biosensing materials, and they are gold nanoparticles. And this is quite interesting, and how they change color from blue to red or purple based on the formations and the designs and the structure of these gold nanoparticles. And they exhibit environmental dependent optical emissions, so the color change for patients. So the patients will know, okay, I actually got decent biofilm or contamination in the lens case, and it's my time to discard it. Because they absorb, and if patients are ever compliant, I guess, so so they can at least see the color, because the color changed to purple, you should now change your lens case. So one other aspect I want to mention is, I thought it's quite clever, is to have more of an aesthetic, non-disposable lens case. And these are essentially hardy metallic-ish lens case, but it has disposable plastic inserts. So what's happening is, we're talking about daily disposable lenses. What if the cup of the lens case can be replaced every week. And that will completely bypass, not complete, it will reduce the compliance problems. And also the question, how often should I replace the lens cases? So it has a cup, it's a cap at the top, and we can ask, based on the research outcomes still pending, we can suggest, okay, every week you change the lens inserts. And also it's more sustainable, less use of plastic, and you don't have to replace the whole lens case. So this is the few directions that I thought will be quite interesting. So a good pairing of daily disposable, which Loretta said, and also with more of a disposable insert lens case can actually perhaps reduce contamination. And I hope it will reflect reduction in inflammatory events.
Yeah, and I think that's a good point, Deborah, because we know that, you know, Loretta's beautifully talked about the non-compliance with replacement of the lenses. We know that patients are also terrible at being compliant with replacing their lens case as well. So those two issues certainly do lead to more complications. So thanks very much, both. Fantastic information from both of you. Thanks for sharing that information. Some real tips and information, I think, there for eye care practitioners when they're dealing with patients, both those with current infection and inflammation, as well as trying to avoid that for future patients. So thanks very much for sharing your insights into this critical topic of how we can minimize infection and inflammation, both with today's patients as well as looking forward into the future. So thanks everyone for joining us. And just a reminder to look for prior episodes of Contact Lens Spectrum Live on the Contact Lens Spectrum page on Facebook, LinkedIn and YouTube, and also on contactlensspectrum.com. As well as now the transcripts of the show. Each show now appears in the printed version of Spectrum each month. So plenty of opportunity to be able to catch up with these great hints and tips from my colleagues in this issue. So join me next month for our conversation with this time Dr. Carol Maldonado Codina from the UK, from the University of Manchester, where we'll be discussing future options to optimize vision in our contact lens wearers. And that issue will be aired on Thursday, October the 5th at noon Eastern Time. Please join me in thanking our two guests, Loretta and Deborah, for sharing their insights with us today. And thanks very much to you for joining us. Thanks a lot. Bye-bye.